Okay. Good morning and assalamu alaikum everyone. I'm Dr. Asif. Today we would like to discuss a bit about carcinoma stomach. Last Friday we have discussed a little bit about carcinoma breast. I think it's very short presentation. If further classes are necessary, we will come to you with, we will discuss with our organizers. This would also be a short discussion about the carcinoma stomach. You know, it's a very, very important and a very, very large topic. I mean, there is no way you can finish it in even 2 hours, but I've been given only 1 hour, and I will try to the best of my capabilities to do utilize this time. Now, I know that third year, fourth year, fifth year, and final year, everybody is here. So I'll try to make it as comprehensive and as simple as possible so that everyone can understand. Carcinoma stomach. My approach today would be a little like the last, the Friday's one. It would be a clinical one. I will start as if I'm taking the history of a patient in the ward. And in the meantime, I will discuss a little bit about the theories as well. Hopefully it would be helpful for everybody. Okay, let's start. So whenever we are taking the history, first we start with the particulars of the patient. And as you know, everything, even the particulars of the patient, in case of carcinoma stomach, are very important. Number one, the age of the patient, usually 50 years or even nowadays 40 years. Even younger patients are also becoming affected by this malignancy nowadays. But definitely, whenever a patient comes to you who is elderly, above 50 years old, and similar features are there, certainly the chance of a malignancy must come to your head. Male patients are more prone to clear stomach, but female patients are definitely there, but commonly male patients are affected by it. Occupation. Now, there is no exact relationship with occupation, but in some books, there is some relationship has been shown with dye industries, rubber industries. Also, I think definitely anybody who is in an occupation which is related to radiation are always more susceptible to any type of malignancy. So I think in any kind of malignancy, occupation is an important point. Chief complaints. This is the most important part. Now, I know that you have your own way of writing these things. Definitely you know how to write the chief complaints. What I do in any malignancy, I try to divide my features in these small subgroups. You can have your own subgroups as well. There's no book where this is written. This is just for my own benefit, and maybe if some of you think it would be beneficial, then you can go for it. All malignancies have this type of features: early asymptomatic, early symptomatic, advanced, emergency features, metastatic, and non-metastatic features. Now, in case of carcinoma stomach, what happens? In the earliest stages, you all know, if you have read the Bailey and Love, that the earliest feature are asymptomatic. There is actually no features. In fact, earliest features are very non-specific, which is previously used to read new onset dyspepsia at the age of 40. New onset dyspepsia. What is dyspepsia? Dyspepsia is indigestion, upper abdominal discomfort, maybe upper abdominal pain, bloating, gas. These all things, this spectrum, all these symptoms together make up dyspepsia. So any of these features in a case of a patient with who's above 40 or 50 years old should definitely concern you as a case of malignancy. You must exclude whether the patient is having any malignancy or not. Now come to the advanced feature. What do you mean by advanced features? Advanced features. In case of malignancy, what are the advanced features they're having? All types of malignancy, especially gastrointestinal malignancy, when they're advanced, they do two things. Number one, they bleed, and number two, they try to obstruct the passage of intestinal contents. What happens in case of carcinoma stomach? It's an upper GI problem, as you know. So whenever it is causing obstruction, what would be the feature? The feature would be vomiting. And if it bleeds, it would be blood-stained vomiting or hematemesis. What can be the emergency features? Emergency features can be anything from acute obstruction. It can be severe bleeding from the malignancy, or sometimes even perforation, which is very deadly. It's very difficult to save the patients in this case. It's very, very advanced. Metastatic features. You all know about the metastatic features. Commonly, metastasis happens to the liver, lungs, and bones. So if it is in the lungs, it would be cough, chest pain, respiratory distress, maybe, hemoptysis, maybe. What are the non-metastatic features? Non-metastatic features of carcinoma stomach would be, the migratory thrombophlebitis is one of the non-metastatic features. It is also called the Trocheus sign. The migratory, it is not really a metastatic feature, but it is due to the thrombotic features. Any malignancy secretes some like gastric malignancy secretes some thrombotic materials in the blood, which causes this migratory thrombophlebitis. If you read the Bailey and Love, it's written over there in the last line of the symptoms. It is written over the non-metastatic feature. So what are the features? So I have discussed. Usually in the ward, we usually get patients related to one of these features: upper abdominal pain, discomfort, loss of appetite, weight loss, advanced features like abdominal lump, obstructive features like intestinal distension, abdominal pain, and bleeding in the form of hematemesis and melena. So one of these features. I'll give you a short example of what can be a history of present illness. I have deliberately chosen pain so that I can describe the pain a bit, so that you can understand how to describe this, how to write the history. This is for the third year students, really. If you guys are interested, you can have a look. Now, this is a way I write the present illness. Now, you can have your own ways, and I always prefer that it should be individualized, it should be personalized, which is comfortable for you and which is easy for you to write and then repeat the thing to a senior professor. So what I would say is that the first line usually starts with, according to the statement of the patient, he was reasonably well, let's say about 5 months back. Then he felt pain in the upper abdomen, which was gradual in onset, burning in nature, moderate in intensity, non-radiating, lasting for hours, maybe aggravated by food, and relieved by anti-gastric medication. Now remember, even in case of carcinoma stomach, the deadly thing is that whenever the patient is taking anti-gastric medication, usually the upper abdominal pain subsides, which makes the patient to believe that it's probably a case of peptic ulcer disease. But this is something much deadly is happening. That's why in the first slide, I've told you that whenever a patient comes to you with any upper abdominal problems, especially above 40 years old, you must think that whether the patient is having a malignancy or not. Okay, then For the last 2 months, he's suffering from vomiting, which is projectile in nature, which may be projectile in nature. When it is projectile in nature, whenever there is gastric outlet obstruction. If it is not no obstruction, then usually it is not projectile in nature. Okay, containing undigested food materials of previous meal, which is not bile stained. That means the obstruction is somewhere before duodenum, but it is blood stained. So it's a type of it may be a hematemesis may be present, and the patient almost every CS stomach patient I have seen has this problem, that is severe loss of appetite. Severe loss of appetite. And whenever the patient is taking food, he has no interest in taking food, in all types of food. It's very important, in all types of food. And what that causes is significant unintentional weight loss of about 10 kgs. So it must be significant, it must be unintentional. Don't make someone is doing a dieting, and if he loses weight, don't make it as if he's having a malignancy. So if it's unintentional weight loss, which is round more than, usually what we say is more than 10% of the body weight in 3 to 6 months, then we say it's a significant weight loss. This can vary, but remember this thing, that it should be unintentional. It should be unintentional. He is tired, that is, he is weak, he's tired from all the time, and which is unable to do his daily activities. Why he is tired? Maybe he's not taking enough food. Also, because of the bleeding, these patients have severe anemia, so which results into this lethargy or malaise. His bladder habit is normal, but complains of occasional passage of blackish stool. Now remember, you should not use any medical terms in the history of present illness or even in the chief complaints. Only place you are allowed to use medical terms will be in the salient features. I'll come to that in later. So don't write the patient is having melena. Write the patient is having blackish stool. And in the end, because whenever anybody is reading your history of present illness, he should be able to understand that which way you are going. And from the previous lines, you can understand that I am going in the line of carcinoma of stomach. So certainly there should be another question, that whether there's any features of metastasis as well. So in the last line, you can write whether there's any features of metastasis. So I've written there's no symptoms of jaundice. Headache means if there is any metastasis in the brain. Cough, hemoptysis, chest pain, and bone pain. So this is a small way of writing it. Make sure it is conscious, and at the same time it contains all the information. Okay, I think this is also quite a large history of present illness. You can reduce another 2 or 3 lines from it. Make sure it's concise. If it's too large, people are not interested. I mean, it's too large, people get lost in the way that what you're saying I don't understand. So make it concise a bit. Okay, past illness. You can add treatment history, you can add medications here. You can also write it under separate headings, but I am trying to make things short here. That's why I have written all those things under the same heading. What is important past history is whether this patient is having peptic ulcer disease. As you know, that the peptic ulcer disease is long-term peptic ulcer disease is one of the predisposing factors for malignancy. Now, what is important is that you can ask the patient. The patient will say that আমার স্যার অনেক দিন ধরে গ্যাসের সমস্যা আছে. Now you can ask the patient যে তাহলে আপনি এখন আসলেন কেন? The question is why now? You're having that problem for the last 10 years, 20 years, but why now? That's a very important and valid question. The patient will say যে স্যার গত 10 বছর ধরে এই সমস্যা আমার ছিল, আমি ঔষধ খাইতাম ভালো হয়ে যেতাম, কিন্তু এখন সমস্যাও বাড়ছে, ঔষধ খেয়েও কমতেছে না. This is what the patient would say. This is exactly what the patient would say. You'll see that the patient's symptoms are getting worse, and also they're not subsiding with medication. This is very, very important. Now, also previous history of pernicious anemia, atrophic gastritis. If you get this history, you will probably not get this, but these are also other predisposing factors. Another important predisposing factor history you should take, the previous history of gastric resection. Is it there or not? Any patient who has had a previous history of gastric resection is also prone to malignancy. Other history of medications like antigastric medications, PPI, proton pump inhibitors are very important. Antacids, these are important. Allergic history should be taken. Okay, personal history, dietary habit is quite important. As you know, that Japan is in Japan, being a very developed country, they are having one of the massive number of carcinoma stomach patients. It's because because they take very salted and smoked foods. You know, sushi and sashimi and all this thing now they're also available in Bangladesh. So be very careful when you're taking these foods because they also cause carcinoma stomach. Preservatives, whenever the food is preserved for a long time, what happens is when you're taking any food, the first place where it is stored is the stomach. So stomach gets all the hits. So make sure you take good quality foods. Whenever you take bad foods, stomach is getting the hits. Now, whenever some part of your body is getting injured for a long time, what happens? It causes chronic inflammation. And from the inflammation, what happens? From the inflammation, there may be metaplasia, dysplasia, then anaplasia, which is malignancy. So these are very important points. Also, smoking and alcohol. This is always there. In all malignancies, smoking and alcohol is one of the important predisposing factors. Okay, now comes the family history. Family history, most importantly, whether the parents are alive, the brothers and sisters, what's happened to them, are they alive, if they have died, whether there's any disease, whether it's a malignant disease, even they're alive, whether there is malignancy that runs in the family, you should take. One of the features, I know in Bangladesh, we will not be able to get these features, but in the developed world, they can also assess whether the patient is having HNPCC, which is hereditary non-polyposis colorectal cancers, and APC, which is adenomatous polyposis coli. Now, if in a family these genes are running, then all the members are at risk of many different types of gastrointestinal malignancies, including carcinoma stomach. So if you can take this history, this will definitely, you'll be able to deduce from this history that whether the patient is having a carcinoma stomach or not. Socioeconomic status. Now, if you look at this, that in Japan, there's a lot of patients with carcinoma stomach. Even in Bangladesh, there's a lot of patients with carcinoma stomach. What is the difference? I mean, definitely we have very different types of food habits. Our quality of life is also very different. But what's happening here? What's happening in Japan is because of the salted and smoked food that is causing irritation in the stomach, which ultimately results into carcinoma stomach. What happens in Bangladesh is just the opposite. We take because the poor people in Bangladesh take very poor quality foods, which are not prepared, which may not be preserved properly. Poor quality water they are taking. There is also history of peptic ulcer disease. There is also history of Helicobacter pylori infections. Now, all these things causes malignancy in the stomach. The difference is mostly in the developed country, the malignancy takes place in the upper stomach. And in the poorer countries, the malignancy is happening in the lower stomach. We will discuss more about this in the further slides. Immunization history, definitely you have to take. Always remember to take the history, whether the patient is BCG vaccinated or not, any chance of tuberculosis in Bangladesh, which is very common. So the history of TB should be there as well. After taking the history, we take the general examination. Now, what are the things that are important? I didn't write all the points. Appearance, definitely the patient would be ill looking. You'll see the nutritional status. The patient will be having very low BMI. The nutritional status may be poor, or patient will be undernutrited. The patient usually is severely anemic. Jaundice may be present. Edema may be present. Edema, it may be nutritional edema because there is lack of protein in the body that causes edema sometimes. Cervical lymph node must be checked. As you know, the left supraclavicular lymph node or the varicose lymph nodes may be enlarged. Dehydration, because the patient may be vomiting, so dehydration. Pigmentation, that is another point. I will come to that very quickly. As you can see, this patient is having, this is called the left supraclavicular lymph node enlargement. This is also called the varicose lymph node. Now you can get, usually this is a very large lymph node, but you must be very careful during examining it because sometimes the lymph nodes are very small, but they are palpable. Now, as I was talking, whether this patient is having any pigmentation. Now, most people would, many of the people will not know that there is also, there's an association with a type of pigmentation with carcinoma stomach that is called acanthosis nigricans. This is the darkest pigmentation in any part of your body. It can be in the neck. It can also be in the axilla. So it is associated with carcinoma stomach. Migratory thrombophlebitis or Trocheus sign or Trocheus syndrome. This is associated with quite a number of GI malignancies. One of them is gastric carcinoma, another is pancreatic carcinoma. What happens is in this type of malignancies, they secrete some thrombotic materials in the blood, and which causes thrombophlebitis. Why is it migratory? It is migratory because it changes the site. Maybe sometimes it is in the proximal foot, then it would be in the distal foot. So it is very important that you understand these things. Okay. Now, local examinations. After the general examination, you come to local examination or the abdominal examination. What will you get in case of a carcinoma stomach in the abdomen? Usually the stomach, the abdominal shape is scaphoid. Because of the weight loss, there may be scaphoid, or even maybe abdominal distension may be present. Why? Because of obstruction, because of ascites. Sometimes the SARC asks you direct questions like this. Like, can the patient have abdominal distension in the case of carcinoma stomach? What the answer should be yes, sir. There may be obstruction, there may be ascites, or there may also be an abdominal lump, which may look like in case of abdominal distension. There may also be visible peristalsis if there is signs of gastric outlet obstruction. This is Sister Mary Joseph nodule. This is found in and around the umbilicus. You can also find it. This is a sign of very advanced cancer. Palpation. Palpation, in case of gastric malignancy, there may be epigastric tenderness. If you feel any lump in the epigastric region, make sure you write down the site, usually in the epigastric region, the size, whether it's fixed, which is very, very important, very important. Now, remember one thing. Any abdominal lump, in case of any malignancy, is a sign of advanced disease. It may be gastric carcinoma, it may be colonic carcinoma. And whenever a lump is palpable, it is usually very difficult to remove the malignancy surgically. So it's a sign of advanced malignancy. Always you should concern whether you'd like to give the patient, if you'd like to go for a neoadjuvant chemoradiotherapy or not. And if it is fixed, that's a definite sign of a definite sign of an advanced disease. Movement with respiration. Sometimes you may be confused whether this is an enlarged left lobe of the liver. So usually the left lobe of the liver will move with respiration. The stomach usually does not move with respiration. Liver should be palpated because there's a chance of metastasis to the liver. Fluid trill, whether there's an ascites or not. Succussion splash, which is if there's an obstructive feature or not, if there's features of obstruction. Remember, the succussion splash should always be done at least after 3 to 4 hours after taking the last meal. You must ask the question to the patient that when have you taken the last meal? And it should be at least 4 hours because that is the gastric emptying time. And if there's food and liquids remaining even after 4 hours, that's a sign of gastric outlet obstruction. Krukenberg's tumor, these are usually metastatic gastric malignancies in the ovaries. That's pelvic malignancies, which are these are Krukenberg tumors. Usually Krukenberg tumor, I have never palpated it, but sometimes you can palpate it parabdominally. I have never done it, but you can, if it is palpable, then it would be definitely this is a sign of advanced disease. Percussion, again, go for shifting dullness. Auscultation, auscultopercussion. Nowadays we do not do it, but you should know what auscultopercussion is. Auscultopercussion is an examination done to delineate the greater curvature of the stomach. It usually enlarges in case of gastric outlet obstruction. You use a stethoscope which you put just over the stomach and you try to make some sound, maybe with a pencil or pen or something, or just tapping motion. And whenever you are inside the stomach, I mean, you're tapping over the skin, and where you're just over the stomach, the sound would resonate. The sound is increase in intensity, and you can understand that you are just above the stomach. So that way you can delineate the greater curvature of the stomach. This is not important. We nowadays don't do it, but it's always better to know because some may ask you about this, and if you can answer that, you get some extra points for that. Parectal examination, very, very important. You must do it. And what you'll get here, you may get, is rectal shelf of Bloomer. I don't know if I've written the spelling of Bloomer correctly. Check it out. I think it may be 2M. I don't know. Rectal shelf of Bloomer. What is this? This is actually peritoneal seedling in the pouch of Douglas, or the rectovesical pouch in case of male, or the rectouterine pouch in case of male, in case of females. What happens is, if there is peritoneal seedling or peritoneal metastasis, when you do a digital rectal examination, sometimes it is palpable. It is not very uncommon. I did palpate it once, so you may be able to palpate it. So make sure you do a digital rectal examination. You try to go all the way up, put the whole finger, and try to palpate the pouch of Douglas, and there's a chance that you might get the rectal shelf of Bloomer. Once you get it, you'll never forget it. Okay, salient features. Now, I did not want to write the salient features. I wanted you guys to write it, but I wrote it anyway for you guys to have a look so that you understand. Now, what happens in the examinations, most of you guys write a very large salient features. Now, remember, salient feature would be a very short description. Imagine that you guys are with the professor giving the round, and the sir asks, what is this patient? You'll get only 1 minute or 30 seconds to discuss what this patient is. You cannot say, you cannot take 5 minutes to describe what the patient is having. So within the 30 seconds, you must be able to say all the important positives and all the important negative points. So that is what you have to do in the salient features. And sometimes in the an examiner may just ask for the salient features. So it is very, very important that you be able to write a good salient feature. Let me show what I have written. Mr. X, 50 years, a farmer from Borishal, was admitted with the complaints of dyspepsia, hematemesis, severe anorexia, significant weight loss for 3 months. He also has melena, but no metastatic features. Now look, I have used medical terms here. Remember that in salient features, medical terms can be written. On examination, he is icteric. The patient is icteric, severely anemic, and has palpable varicose glands. On examination, don't say on examination, just say it in one go. He has a mass in the epigastric region, which is 10 by 8 centimeters, hard and fixed. So this is all that should be needed. Now, whenever I'm saying this, if you close your eyes and think what I'm saying, you'll understand that I'm talking about carcinoma of stomach. So this is very important. Make sure salient features should usually be 3 paragraphs. Don't go more than five or 6 lines. I think 5 or 6 sentences is enough. If you can explain something, if you can't explain something in 5 or 6 sentences, you cannot explain it ever, really. So make sure you write something like this. This is I think this is a very nice presentation of all what we have said. Try to write your salient features the way I have written it. I think that should give you more points in your examinations. But of course, remember that thing. One thing is that this is always, again, individualized. This is personalized. You can always write it in your own words. You can write it in your own format, whichever is easy for you. You can certainly disagree with me that you should have written that one first, this one second. It doesn't matter. Make sure the points are there, important, negative, and positive points are there. That is what is important here. But always write it the way you are more comfortable, that you are more comfortable saying it. So write it the way you want it. Now, the provisional diagnosis, then comes a provisional diagnosis. You say, it's a case of, my case, this is a case, it's probably a case of carcinoma of stomach. You can add a feature, add some more information like advanced carcinoma of stomach, if there's a lump over there, or if there's features of gastric outlet obstruction, then you say, so it's a case of carcinoma of stomach with gastric outlet obstruction. Differential diagnosis. Now remember, this is always, don't go for all those differential diagnoses at a go. It should be according to your clinical features, and usually write 2, maximum 3 differentials. Don't go for 10 differential diagnoses. Okay, so if your features are something like, okay, so it's a case of gastric outlet obstruction, you can also say, so maybe a case of peptic ulcer, chronic peptic ulcer disease, or chronic duodenal ulcer with gastric outlet obstruction. You can write something like that. Also, other features of gastric malignancies like lymphoma, GIST can be there. Sometimes it can be even, if you get a lump in the epigastric region, what are the other differential diagnoses? One is carcinoma transverse colon. Now remember, don't go for carcinoma transverse colon after the salient feature that I have given. And if you write a salient after the salient feature, my salient feature, and then you say one of my DDs are carcinoma transverse colon, then you are definitely going to fail. That's how I would understand you have no idea what carcinoma stomach is, and you have no idea what carcinoma transverse colon is. Now, remember, sometimes there can be very, very absurd DDs as well, like advanced CI gallbladder. What happened is once I took history in one government medical, and I thought this is a case of carcinoma stomach, and I have written it like that. That's a case of carcinoma stomach. And after CT scan and all the investigation, it came out to be a case of advanced CI gallbladder. Now you can say definitely that, sir, you are not good at taking histories, but not only me, there are 3 or 4 other people, they also thought this is a case of advanced carcinoma stomach. And later it came out to be a case of carcinoma gallbladder. So these things can happen, but don't write this sort of things. Don't write absurd things. Remember, rare things happens rarely, common things happens commonly. And your differentials and your diagnosis should be the common thing. Okay, if you think it's a case of carcinoma stomach, you should not write gist of the stomach, GIST. You should write carcinoma stomach, which is more common. You can also write peptic ulcer disease, which is a common finding. In fact, everybody in Bangladesh has it. So make sure you understand that thing, and remember that common things happens commonly. Okay, so after that we come to the investigations. Now, what are the investigations that we'd like to do? The number one, if you always categorize your investigations in 3 stages, in case of a malignancy, the number one investigation should be the ones you use to confirm a diagnosis. This is to confirm a diagnosis and to exclude the differential diagnosis. What is that investigation? That is the endoscopy, upper GI endoscopy. Remember, endoscopy means nothing. It should be upper GI endoscopy, because there is also a lower GI endoscopy as well, that is called colonoscopy. So you should write upper GI endoscopy and biopsy. This is very, you can have a visual look at the malignancy, at the lesion. You can take biopsy from it. A common question is how many biopsies you should take. Now remember, biopsy should be, you should take at least 6 biopsies, and or maybe a maximum of 10 biopsies. Now what is important here is how do you understand that adequate amount of tissue is there? Whenever I'm taking biopsy during a colonoscopy, number thing is I'll always look at it, how much biopsy I've taken, whether there's adequate tissue. Even after taking 10 biopsies, if you think there's not adequate tissue, then take 11 or 12 biopsies. Okay, just make sure that don't take too many biopsies and perforate the malignancy, because that also has happened. So it's will be very careful. You must have a training before taking biopsies. And another thing, how do you understand that enough tissue has been taken? Whenever you take biopsy, you'll see immediately there will be some bleeding from the site of biopsy. So that will help you understand that you've taken enough tissue. Sometimes what happens is we only take the necrosed tissue. Sometimes we only take mucus. So you must be very careful. And when you send it to the histopathologist, he has no understanding of what is happening, and the patient is very depressed. That again, you have to take the biopsy, because these tests are expensive and also very difficult for the patients. Number one is, so we have done the confirmation. So once you have confirmed that this particular patient has carcinoma stomach, then you stage the disease. Now, of course, in Bangladesh, we do all sorts of investigations like ultrasonogram, chest X-ray, liver function test, because other investigations are very expensive, sometimes are not available. But if available, okay, there are a lot of questions coming. I'm just having a look. Is there a difference between? Okay, thank you for the question. One of you guys asked me a question whether there's a difference between carcinoma stomach, clinical features of carcinoma stomach, and GIST. Now remember, thank you for the question. That's a very excellent question, really. One of our medical students have asked a question that whether there's a basic is there a difference in clinical features, different carcinoma stomach and GIST of the stomach. Yes. Now remember, carcinoma stomachs are usually an ulcerative lesions, and GIST is what? These are sort of something, there's one of the connective tissue tumors. That means it is usually always covered by mucosa. So the chances of bleeding are very less in case of GIST. You will almost never get features of bleeding in GIST. But features of malignance, in case of carcinoma, you will get features of bleeding. Number one thing. Yes, you can also get features of bleeding in GIST in very advanced stage. What happens is when it becomes so large and there is pressure necrosis of the overlying mucosa, then there is a chance of bleeding. But usually in the early stages, there is no bleeding. So that is, I think, one of the important points, important points between between the clinical features of GIST and carcinoma stomach. I will discuss this in the future, but today actually I don't have a lot of time, so I'll have to finish the slide. I'm sorry for that, but if I get another class, I will categorically show you how GIST of the stomach, lymphoma of the stomach, and carcinoma stomach, they are different. So today, let's just finish this first. Then I'll take the questions as well. Okay. Now, what is the best investigation for carcinoma stomach? And in that case, any cancer of stomach, it is CT scan of the whole abdomen and chest. Now, remember, CT scan is not always available. It is quite expensive. It's not affordable. So the first investigation, whenever the teacher will ask you what would the staging investigation, you'll say ultrasonography, whole abdomen, chest X-ray, liver function test. These are the three investigations that we always do. Barium meal study is something which used to do. Nowadays, we very rarely do it, not necessary, but you can also talk about it, barium meal X-ray. But at least you must be able to read the X-rays of barium meals. Very, very important that way. Endoscopic ultrasound, which is a very, very good investigation. I'll just come to you in the future slides, how it looks. Serological markers. Now, these are the serological markers. Remember, they have a low sensitivity and specificity, but what is important is they give you an idea of how advanced the malignancy is. And another important thing is, before the surgery, you take the baseline level. For example, in colon carcinoma, what we do is that before the surgery, we take a CEL level before doing the surgery. Let's say the CEL level is 20. And then after the surgery, after 6 months or 1 year after the surgery, we check the CEL level, whether it is increasing, whether it is decreasing, whether it is staying the same, because that gives you an idea of the progression of the disease. So they are not really sensitive or specific, but you can have an idea of the progression of the disease from the serological markers, and also the idea of whether the disease is advanced or not. And the last group of investigation that we should do is about the fitness of anesthesia and surgery. There you do a complete blood count, you do a serum electrolyte level, creatinine level, and all those things, all those investigations that we are doing repeatedly. So the investigations in case of a malignancy should be under two headings. Number one, to confirm the diagnosis and to exclude the differential diagnosis. Number two is the staging investigations. Number three, for fitness and surgery. Okay, so this is what you usually see in case of endoscopy. There may be bleeding. It's usually an ulcerative lesion. That's what you see. Normally, if it's a peptic ulcer disease, you'll see it's flat. There's an ulcer, but it's flat. But in case of malignancy, it is an ulcerative disease. That means it is elevated. In case of endoscopy, you take biopsy, you take at least 6 to 10 biopsies. Make sure you take adequate tissues from the right areas. What would be the right area? The right area should be in and around the periphery of the ulcer. Don't take it from the center of the ulcer, because those tissues are necrosed. So you should try to take it from the periphery of the ulcers. Okay. I'll take this slide to discuss a bit of theory right now. What are the histological types? What you need to know is most important. 90% of the cases, they're adenocarcinoma. There may be lymphoma. There may be GIST or gastrointestinal stromal tumor, squamous cell carcinoma, carcinoid tumor. We will discuss all about this. Maybe if we are lucky, we'll get it in a second lecture, but not today because I'm running out of time. So we'll go forward. Classifications, clinico-pathological classification, Lawrence classification. It is very, very important. You must all learn about it. Lawrence classification. What is Lawrence classification? It divides the malignancy, gastric malignancy, into two types: the intestinal type and the diffuse type. Now, these are some of the differentiations. Usually, the intestinal types happens after long-term peptic ulcer disease, after intestinal metaplasia or gastric atrophy. Usually, it is with the elderly people, elderly patients, and younger patients have diffuse malignancy. And diffuse malignancies are poorly differentiated. They're spread throughout the uh, walls of the stomach, and they have early lymphatic spreads. And and the prognosis is very, very bad in case of diffuse type of CS stomach. In fact, both of them are bad, but comparatively, diffuse type of carcinoma stomach is quite bad. You know that I'm sure you've heard of the term linitis plastica or leather bottle appearance, which you see in case of in a case of barium meal. If you take a barium meal X-ray, those are usually diffuse type of carcinoma stomach. This one, if you look at this, this is actually a intestinal type, and this is a diffuse type. Where in diffuse type, the carcinoma usually may not be visible to you, because it has spread throughout. It's an infiltrative type of malignancy. It has spread throughout the wall of the stomach, and this is one of the indications for total gastrectomy when you have diffuse type of malignancy. Another type of classification that we do according to depth of invasion is early gastric cancer and advanced gastric cancer. Early gastric cancer means it involves the mucosa and submucosa. Now here comes the important part: with or without lymph node involvement. Remember, lymph node may be involved, but until and unless it has invaded the muscle layer, it is always an early gastric cancer. And if it has invaded the muscle layer, it becomes an advanced gastric cancer. This is very important. Remember, in this case, lymph node involvement is not an issue. What is issue is whether it has invaded into the muscle layer or it has not invaded. If it invaded into the muscle layer, it's an advanced cancer. If it has not invaded into the muscle layer, it's an early gastric cancer. These are all written in Bailey and Love. These are all very important. This will be asked to you in examinations, in items, and everywhere. So you must make sure that you understand this. These are very simple things, but very important. Now, this is the Japanese classification of early gastric cancer. There's usually three types: the protruded, superficial, and excavated type. The superficial type can be divided into three types again: the elevated, flat, and depressed types. These are again given in Bailey and Love. Have a look at the pictures. Those pictures are, I think, better than this one. So just have a look at this. Not necessary that you have to remember this thing, but during the examinations, the SAR may ask you these questions. So better be able to say this. In the Japanese classification of early gastric cancer, there are three types: superficial, protruded, and excavated. The superficial type is again divided into three types: the elevated, flat, and depressed type. And the Bowman's classification of advanced gastric cancer. This is protruded, ulcerated, infiltrative, and diffuse. Now, this diffuse type is, if you remember, the diffuse type of gastric cancer. It is also called the linitis plastica. This is the type 4, as you can see here. Okay. Now, the barium meal X-ray, as you can see, there is a defect. The defect is persistent. Remember, you must say there is a persistent defect. Persistent, why? Because there can be also peristalsis. So the defect must be persistent. In 2 or 3 slides of the X-ray or the barium meal, if you look there, it's always there. It's always there, because it may also be a sign. It may also show a peristalsis, but in the case of peristalsis, the site would change. But in case of malignancy, the site would remain the same. So it's a persistent filling defect, as you can see over here. This is just to show you what the endoscopic ultrasound looks like. You just have to know the name. At undergrad level, no one's going to ask you what to check out the endoscopic ultrasound. In fact, it is not routinely done in Bangladesh, but have a look at it. This is how it is done. The different layers of the stomach, as you can see over here, the ring-like. The rings are actually part of the part of the endoscope that gives you an idea where each and every layer is. So just have a look at this. You don't have to learn about it. I mean, even in postgrad level, nobody really expects to understand the endoscopic ultrasound, but you must be able to read the CT scans and the ultrasound, the normal ultrasound. You must be able to do that. Achha. Here is a TNM staging. I'm sorry, I could not put it in one page. It was very difficult, so the things are very small, but it's always the same. The T1 looks like, the T1 it invades the lamina propria, muscularis mucosa, and submucosa. The T2 invades the muscle layer. The T3 penetrates the muscle layer into the subserosal layer, and the T4, it invades the serosa and the adjacent structures. Just have a look. This is very simple. But what is important here is you must learn about the lymph node, the regional lymph nodes. I mean, just have a look. You don't have to memorize it at undergrad level, but have a look at it. N0 means no lymph node involvement. N1 means 1 to 2 lymph nodes. N2 means 3 to 6 lymph nodes. N3, and so on like this. Now, I'll come to you why I'm talking about the lymph nodes, because this is very important if you want to do the surgery correctly. So the surgical part is very much related with the lymph node metastasis and the lymph node clearance. Okay. Spread of gastric cancer. Spread of gastric cancer. So where are the places they get spread? Direct spread into the muscle layer, serosa, and then into the adjacent structures like pancreas, the colon. It can, very advanced gastric cancer can invade into the colon and cause gastrocolic fistula, which is a deadly disease. You'll see that the patient is actually vomiting stool because there's a gastrocolic fistula. It's a very, very devastating disease, and the patient you will not be able to save the patient. It's a very advanced case. You usually see those things in very poor patients, those who have neglected their disease for a long time. I have seen 2 patients in my life, and very deadly, very, very distressing for the patients. Lymphatic spread, definitely. Usually the intra-abdominal lymph nodes, you will not be able to palpate. The only lymph node you will be able to palpate, probably the very advanced case, are the varicose nodes. The blood-borne metastasis, first to the liver, lungs, bones. These are the usual sites of metastasis. Now, there's another metastasis, that's transperitoneal metastasis. That is peritoneal seedlings. There may be ascites, Krukenberg tumor in the pelvis. The ovaries may be also, there may be metastasis into the ovaries. It's called the Krukenberg tumor. Sister Joseph nodules in the umbilicus. These are all signs of advanced disease. Remember, transperitoneal metastasis is always a sign of advanced disease. Okay, CT scan. Now look, if you look at this, look at the CT scan. This is the stomach, this is the liver. If you look at the stomach over here, it has the malignancy has invaded into the fat plane, which is lying between the stomach and the pancreas. That means this is an advanced disease. This is this probably would be an irresectable cancer. I will come to those points. They're very confused with everybody's confused with what do you mean by incurable, irresectable, inoperable cases. It's a good chance to talk about this. Incurable means we may be able to do, incurable cancer means we may be able to do something about it. We also may be able to do some surgeries with this patient, chemoradiotherapy, but nothing will ultimately cure this patient. For example, if it's a very advanced malignancy, you do a gastrojejunostomy. You do a gastrojejunostomy, and which will relieve the obstruction. So the case is incurable cancer, but you have done something. A palliative surgery you have done. A patient may come to you with a case of advanced gastric cancer with multiple liver metastasis. This is an incurable cancer, but you may be able to resect the whole stomach and do a reconstruction. So these are called incurable malignancies. So that means that you cannot take the whole malignancy out of the body, but some surgery can be done. Inoperable case. Inoperable case usually means, for example, in a case of malignancy, maybe an advanced malignancy, the patient has liver metastasis, but the malignancy in the stomach is quite mobile, and you remove the whole stomach and do a reconstruction. Now, in this case, it is an operable case. we have done an operation on this patient. But again, you have not cured this patient. But irresectable. Irresectable means what? Whenever the tumor cannot be, the tumor, whenever we're saying irresectable, it means the tumor cannot be removed. I wish I could show you a picture of it. Let me see. Let me see if I can draw something for you. Then I think you'll be able to understand this thing better. Okay. Hopefully you can see. Now let's say this, if this is the stomach, let's say there is a malignancy over here, which is quite mobile. And let's say this is the liver. I'm sorry for my drawing, it's not good, I know that. There are multiple liver metastases. Now, what happens is you can remove this part of the stomach and do a reconstruction. Now, this is an incurable disease, but not inoperable, not irresectable. It can be resected, it can be operated upon. But what happens if this malignancy is very, very big and it has invaded into the other parts? Now, there is no way of bypassing this. You cannot bypass this thing. You can do nothing about this. No surgery is possible. No resection is possible. So this is a case of, this is incurable, irresectable, and inoperable. Okay. Now, let's say another case. When it is operable, let's say this is the stomach, but there's a very large malignancy over here. Now, this tumor is large and it is fixed to the pancreas. It is fixed to the pancreas. It is fixed to the pancreas. Now, this is an irresectable cancer. You cannot resect the cancer, but it is not an inoperable case. You can do something about it. You can do a gastrojejunostomy over here. And food can pass from over here to there. You can do a gastrojejunostomy. So this is an incurable cancer, inoperable, irresectable tumor, but you can do an operation over here. You can do something over here. So this is called an operable tumor, but it is incurable and irresectable tumor. Hopefully I could make you understand this thing. So there are three terms: incurable, when something can be done, but tumor cannot be removed as a whole. This is incurable. Inoperable means when the tumor, there can be no operation can be done, nothing. The tumor is so large, no operation can be done. But in case of irresectable tumor, the tumor cannot be resected, but some operation can be done. That is in the form of a palliative gastrojejunostomy may be done. Okay. Let's get back to the original slide. Okay. So in this case, if you look at this, whenever the cancer has invaded into the fat plane, this becomes an incurable and irresectable tumor. You cannot resect this tumor, but maybe operation can be done over here. Now have a look at this. Look at this. Multiple liver metastasis. There's multiple lung metastasis. These are definitely incurable cancers. Nothing can be done. You cannot take the whole liver out. You can take all the lung out. So this is an incurable cancers. But the CT scans are very, very good investigation. This is where I say that whenever you see a malignancy, the best investigation for staging is CT scan. If the SAR is asking that, if you ask one investigation that you'd like to do, that should be a CT scan. A CT scan of the whole abdomen. That's the most important investigation. You can, in a CT scan, you can anatomically delineate the cancer, whether it is advanced, whether it is locally advanced, you can understand whether there's any ascites present, whether there is any liver metastasis present. You can all find out those things. In fact, only thing you cannot find out in case of CT scan is there any peritoneal metastasis or not. There's another investigation that can be done to check out whether the patient has peritoneal metastasis. I'll come to you in the future. Okay, another investigation that we do a PET scan. Now, PET scan, we usually do not, it's a very, very expensive and it's not available in Bangladesh everywhere. So we do not routinely do it. What you can do in case of PET scan can be done before a neoadjuvant chemoradiotherapy to check, to compare the results of chemoradiotherapy before and after. So that's sometimes when we do a PET scan, but usually routinely we do not do PET scan. Now, remember, if we have a peritoneal seedling, what we can do, we check with a staging laparoscopy. Remember, nowadays what we do before undergoing a surgery, we always go for a staging laparoscopy to check out the peritoneal seedling, whether there's ascites, whether there's liver metastasis. This is always done nowadays. Make sure the examiners will always ask you what investigation, what else can you do? This is the investigation. This is the last investigation that you should do. This is done just before the surgery. So if you check it out, if you see this is an inoperable case, you don't make the patient go through the stress of a big incision. So the patient would be better, and you can go for a palliative, maybe chemoradiotherapy or other palliative means. So after all this, you come to the confirmed diagnosis, which is a carcinoma stomach with hepatic, which may be hepatic metastasis or any other thing. Treatment. Now remember, the examiners are always asking you what is your treatment. Remember, just directly don't go, I'll go for surgery. First you say, sir, the treatment, it depends on the staging of the stage of the disease. Number one, the treatment, what we need is a multidisciplinary team approach. If surgery can be done, we take consent, we counsel the patient about the disease and about the treatment that we are going to provide him with. We talk about the treatment in a multidisciplinary team. What is a multidisciplinary team? A team which includes a surgeon, an oncologist, a radiologist, a pathologist, and any other colleagues that you might need to have. Mainly these four are always there. They together decide that what is the best treatment option for this patient, and then they tell the patient. So a multidisciplinary team approach is necessary. But whatever the approach is, surgery is the only curative treatment. It is also the best palliation, and it also does the most accurate staging. Must remember that. Goal of surgery. What is the goal of surgery? The goal of surgery is only one thing, that is oncological clearance. Now, what do we mean by oncological clearance? Let me, if I have some time, let me just show you a bit. Okay. Again, I'm sorry for my drawing. Let's say this is the stomach. Here is the malignancy over here. And it has also some lymph nodes over here. Some lymph nodes are involved. Okay. Now, what oncological clearance means? It means you take out the tumor, macroscopic portion of the tumor. Number one, you have to take the tumor out. Number one. Number two, you know the tumor is spreading in odd sides. So at least 5 centimeters proximal and 5 centimeters distal. If it is unstretched, if it is stretched, it would be 10 centimeters. So 5 centimeters proximal and 5 centimeters distance. Tumor-free margins together with the lymph nodes. This is called oncological clearance. So in case of oncological clearance, what are the things you're taking out? The tumor, then 5 centimeters proximal and 5 centimeters. Sometimes it can be 10 centimeters as well. 5 centimeters and 5 centimeters distal and proximal tumor-free margins together with lymphovascular clearance. This is called an oncological clearance. Remember this thing. This is called an oncological clearance. So number one goal of surgery is we have to resect the tumor. All margins has to be negative and adequate lymph node. Negative margin of at least 5 centimeters. If it is more, it's better. Then do a reconstruction. Then we do a reconstruction. So remember, oncological clearance is when you can do it. If it is not possible, then the minimum what you have to do. Minimum is maybe number one, just you do a resection. That's what I have said in the past slides. It may be an incurable cancer, but it's an operable case. It's a resectable case. So we have resected the tumor out. We have done a reconstruction and send it for chemotherapy, and let's see what happens. If it is an irresectable tumor but operable tumor, I mean operation inoperable in the form of gastrojejunostomy, then just do a gastrojejunostomy and the patient can at least take food. So that's what we do. Now have a look at this. This is subtotal gastrectomy. This is when the tumor is in the distal part of the stomach. So we do a resection of the stomach followed by Roux and Y gastrojejunostomy. Now remember, we always go for Roux and Y reconstruction. Why? Because there is less chance of biliary reflux. This is the best reconstruction. We can also do a loop gastrojejunostomy. Maybe in another day, if we have some time, we can discuss more about all the surgeries. But today I'm running out of time, so I'll just go short on this. Look at this. It is a Roux and Y gastrojejunostomy. This is the alimentary limb, and this is the biliary limb. It looks like a Y. That's why we called it a Roux and Y. Roux means root like Y. It's a root. It's a rasta. Y এর মতো একটা রাস্তা আর কি. So Roux and Y gastrojejunostomy. This is done. This is subtotal gastrectomy. Okay. This is total gastrectomy. Like it's a proximal tumor. You do a total gastrectomy. This limb ideally should be about 40 centimeters long. The elementary limb should at least be 40 to 50 centimeters long. Remember that thing. It's also written in your Bailey and Love. It's a beautiful picture giving in your Bailey Love. Have a look at it. Palliative surgery. Now, this is what I was talking about. Now, this is an incurable cancer, irresectable tumor, but not inoperable. So we have done an operation here. That is done a palliative gastrojejunostomy. The food could not pass. Now the food can pass directly through the gastrojejunostomy stoma. You can send this patient for chemoradiotherapy, and maybe in the future, if the down stages, this inoperable case may becomes operable, may becomes resectable even. So that's when you do a resection. Lymph node dissection, again, I have to talk a lot about it, but I'll keep it short as much as possible. Have a look at this picture. If you look at 1, 2, 3, 4, 5, 6, these are the N1 lymph nodes. These are the perigastric lymph nodes. Just remember, if you know the name of these 6, I think that's enough. This is the right cardiac, left cardiac, the nose around the lesser and the greater curvature, suprapyloric and infrapyloric lymph nodes. These are the lymph nodes that must always be removed. If you want an oncological clearance, must be removed. So in Bangladesh, we usually do a D1 resection. That means all N1 lymph nodes are removed, N block with the stomach. This is very important. In case of D2, N2, N1 and N2, both are removed. Those are done usually in, I think, Japan, but in Bangladesh, it's quite, in Bangladesh, the standard one is done. That is D1. I think D1 is enough for oncological clearance. In Bangladesh, we do mostly the D1 clearance, but in some advanced centers, maybe D2 also, D2 clearance are also done. So just remember this, just know the names of the first six lymph nodes. These are very simple. If you want to do a D1 resection, then these 6 lymph nodes must be removed for oncological clearance. I think definitely it's a final prof. If you can say the 6 names of these lymph nodes, I think definitely you are going to get a very good marks there. Post-operative complications, the most important post-operative complication usually is leakage from the suture line. You remember the gastrojejunostomy or the esophagojejunostomy, the leakage that can be quite disastrous for the patient. Leakage from duodenal stamp also happens. Nowadays rare, but it also happens. Stomal obstruction, if there's edema of the stomach is too tight, that can happen. Early dumping, late dumping, these are the things you all know about it. But in the future, if we get some time, I'll discuss in further details. And then, of course, we're going to go for chemo and radiotherapy. You've always remembered that chemotherapy can be given before the surgery. That's a neoadjuvant chemotherapy, or it can be given after the surgery, or it can be in an inoperable, irresectable case, give the chemoradiotherapy and downstage the disease, and then it may become resectable and operable, and then you do the surgery. So I think this is, I know this is very short. I know many of you have a lot of questions. Even I also have a lot of questions myself. But hopefully, if you have any questions, you can ask me in the over the net. I'm always there to help you guys. And maybe if the organizers allow us, then we can go for a second lecture in the future. Thank you very much, everyone. Thank you for your time.